We received feedback on care opinion, and it was sent round a group of us and asked who would respond, and I said I was quite happy to put a generic response because it was a patient who felt scared about coming back to hospital because they had a condition that was poorly understood because it was quite rare and they hadn't been getting medications on time, and I said that was fine. I'd put in a generic response. I said, I'm really sorry that happened. It can be really difficult when you've got a rare condition, and would it be beneficial to meet up so that we could plan a care plan that would be able to be put in the notes, put on Symphony or any IT system. They did get back in touch and said that would be really useful, and I felt really positive about it from the beginning. Though it was negative, it was balanced and constructive, and the response that I got back from them was very respectful and positive and constructive, and I think that makes a difference as well. And I got the support of our CNM, and by that point I knew what their condition was, so I was able to speak to one of the specialists about the condition. And myself, the CNM and our senior charge nurse went along to specific training, and we went to the meeting with the patient and their partner, and they were just really grateful that we were concerned about them because they had a chronic condition and would have to come back to hospital, so they were really pleased. We had already set up some documentation from the Royal College of Emergency Medicine website about that specific condition, and they just said that they felt empowered by that. And they had actually had a copy of that when they were first diagnosed but didn't realise the significance of it. One of the learning points, even for me as a doctor, was that they were given steroids, and I wouldn't have known that they were allowed to have it 3 times in a day, and when they had a crisis they should be getting it that number of times. So it was a good learning point for me. We have a board where we share learning called a 1 Minute Wonder Board, and it's basically a PowerPoint presentation of 6 slides that we put up for 2 weeks. We have a summary of it in all of our staff toilets so that everyone can learn a little bit about a new condition, and in that we just summarised the main learning points from a medical point of view, and then the main learning points from the patient's point of view. Like they're the expert of their condition, that they manage it 99% of the time, and if we're privileged to look after them 1% of the time, then we need to listen to them. So if they tell us they should be having it 3 times a day, they're probably right, and if we don't know, we should let them take it because they would at home. And just to really open our dialogue and speak more to patients and try and find out what it's like to live with that, what it's like to be in hospital and all of a sudden not have control. We shared the 1 Minute Wonder with our colleagues in the medical department as well. Shared it with there as well, so that we had a whole organisational learning from it. And I think in terms of care opinion, that sells it. Even if you only have 1 patient, not be scared to come back or prevent an adverse event, then it's worth its weight in gold, isn't it? They talked about feeling disempowered, and the patient started to panic because they knew that they should be getting their medication, phoned home to say, what am I going to do because I'm not getting my medication? And so you can understand the panic that ensues from all of that, but as a doctor I can understand how that happens. Proper communication between the 2 parties to discuss why that happened, and there was no discussion afterwards about whether or not anyone had learned anything from that either. So if that's a place you're going to come back to over the next 20, 30, 40 years, you kind of want to make sure that that's not going to happen again. I think what we ended with was, we can't promise that will never happen again, but now that you've got the documentation and it's in your notes, you can always show them that, and because it's got official guidelines at the top, people are going to go, okay, that will be fine then, and I can still check with my senior, but I'm more likely to prescribe it. But we should be listening to our patients, and it was a really positive experience for everyone that was involved in the meeting, and they were delighted. When we did the 1 Minute Wonder, we sent it to them for approval before we put it out, and they were going to share with their support groups, just to say that actually you can say to the healthcare professionals that you had a poor experience and they can make it better, and actually they do want to. I think that was the only downside, is that people maybe think that we don't want to make it better, or that we might treat you worse if we find out that something hasn't gone well. In actual fact, most healthcare professionals just want bad things never to happen, and will try their best to prevent things from happening. So, yeah. was good.